So for cancer, the two main types of old therapies are chemotherapy, and we had Dr. Pommier talk about topoisomerase inhibitors. And the second main line of treatment is radiation. So today we have Liz Nichols from the University of Maryland. She got her MD degree from Maryland. She did a residency at Maryland, and now she's an assistant professor at Maryland. So the medical school there, it's up in Baltimore. And the title of her talk today is Introduction to Radiation Oncology. Liz.
All right, well, thank you all for having me here today. Can you hear okay? Yeah, okay. As Dr. Moody said, I'm from University of Maryland. We actually have 6 radiation oncology sites across the state. Our main campus is located in Baltimore, where we also have a Proton Center, which is new and recently opened. And then we also have locations in Anne Arundel County, Howard County, Cecil County, Bel Air, Maryland, and so we're a nice network across the state for patients who need our services. So today I wanted to give you guys a little snapshot to talk about what radiation oncology is, how it might interface with some of the work that you all are doing, and give you an idea of kind of what our patients actually go through on a day-to-day basis when they're receiving radiation therapy. I have no disclosures. So our outline for the talk today is to review just some of the general goals of cancer therapy, some of the goals of radiation therapy in general, talk about some of the basics of radiation oncology, and I subdivided this into 4 separate parts. Just a very brief introduction on radiation physics, a brief introduction on radiation biology, talking about radiation therapy, and then we have 2 kind of very common patient case presentations that I thought I'd run through as well. And then also talk about some of the exciting new work that's being done in radiation oncology. So to start off in terms of the principles of cancer therapy, I've generally kind of grouped them into these couple groups here. So one of the things that we want to do is try to minimize therapy as much as we can for our patients, both in terms of minimizing toxicity. So if we can give a patient just one modality of treatment, like surgery or radiation or chemotherapy, as opposed to giving them a combination of those things, that can minimize their toxicity. It certainly minimizes the time that they're in and out of physician offices, and then can also impact the overall cost of the care of their cancer, which is a very big, important thing now in healthcare spending. We also want to minimize the negative impact on the patient's quality of life. So again, that can be through toxicity or side effects of therapy, looking at the remaining function. So for example, a long time ago, for sarcomas, we used to amputate someone's extremity. Then actually through some of the good work here at the NIH, we found that that wasn't necessary anymore. So maintaining function for those patients, and also maintaining cosmetic outcome, which is very important in certain cancers like breast cancer therapy. Cancer therapy can also be used to improve a patient's quality of life. So let's say a patient has metastatic cancer and they have a lot of pain from a spot in one of the bones. We can often use therapy to help improve their quality of life as well as preserve their organs. We also want to maximize the impact on their quantity of life, so cure and remission. And then again, we're always searching to improve outcomes through additional research. So the discipline of radiation oncology, as I mentioned, is really broken into 3 separate areas. So radiation biology, where there's a lot of bench work as well as animal models that we use, physics, as well as radiation therapy that's used therapeutically. So just some of the basics of radiation oncology physics. So when you look at kind of what is radiation, this is one of the general definitions. So it's the complete process by which energy is emitted from one body, transmitted through an intervening medium or space, and then absorbed by another body. There are actually a lot of different forms of radiation. Some of those are natural, some of those are man-made. So an alpha particle is present in our natural surroundings and can be used through decaying nucleus. Alpha particles are very weak types of radiation, so literally a piece of paper can block an alpha particle. So if you guys remember back to the Japanese disasters, they were actually talking to patients about, or people about, wearing clothes to protect their skin, and that was actually to protect them from any alpha particles that may have been in the atmosphere. Beta particles are a little bit more penetrating, but they also generally only penetrate about 2 to 3 millimeters in depth. So something like a sheet of aluminum can actually block a beta particle. And then gamma rays, which are what we often use for therapeutic radiation oncology, actually have the ability to kind of pass through material. And typically we use concrete to shield from gamma rays. So if you ever walk into one of our radiation vaults, the rooms are typically composed of several feet of concrete. Generally, it's about 6 feet or so of concrete for more modern day machines that are utilized. We look at where radiation fits in the electromagnetic spectrum. So we're all the way over here on the left using gamma rays, okay? So again, our visible light spectrum is here, and here's where we're at with giving radiation therapy. So when we look at how are X-rays generated, so in a very simplistic model on the left here, this is a vacuum or an X-ray beam, a vacuum tube where you can generate X-rays. So you generally have this in a vacuum, you have an anode and a cathode, and then the X-ray beam can come out through this area after voltage is applied. The modern day way that radiation is delivered is through one of these types of machines called a LINAC, which stands for linear accelerator. And basically in this LINAC, there's this general concept is built into here, but in a bigger magnitude. So for the LINAC, the patient lays on the table here. The radiation comes out of the head of the machine here, and this part here called the gantry can actually rotate in 360 degrees around the patient. All the other pieces of that are actually located in the body of the machine here. And then believe it or not, there's actually a huge piece of equipment underneath the floor, and then there's typically a huge piece of equipment back here as well. So again, linear accelerators can generate both high energy photons as well as high energy electrons, okay? Generally, the linear accelerators are created to have what we call uniform beam characteristics. So basically what that means is that if I had a radiation beam on and I wanted to kind of scan something across that beam path, that we're getting the same amount of radiation everywhere I go in that beam path, okay? We have the ability to do very precise field shaping through things that are called collimators, which are here in the head of the machine and are kind of depicted here, but probably hard to see. And then we also have precise delivery, where the gantry, as I mentioned, can rotate back and forth. This couch that I was showing can actually also rotate in different directions. And then the patient is also immobilized so that we can have millimeter accuracy. So for example, when we're treating a brain tumor, we usually have a 2 to 3 millimeter accuracy of what we're targeting. When we're treating another part of the body, we may expand that to 5 millimeters depending on what we're treating. There are several different types of radiation planning techniques. Kind of in the modern day, we generally use what's either called 3D CRT, which stands for 3D conformal radiation therapy, or very often also a type of radiation called IMRT, which we'll get to on the next slide. So with 3D radiation, we always use a CT scan to plan from the patient's own anatomy, as well as where their tumor is located, and this allows multiple different angles to be utilized. And basically in the computer system, we can create a virtual patient, we create the radiation plan, and I'll show you guys some slides about that a little bit later to create that plan. When we talk about IMRT, which stands for intensity modulated radiation therapy, what we do with this is it's a different type of software than what we use with 3D conformal radiation. And basically we tell the computer what we want. So I want my tumor to get this dose of radiation. I want the surrounding organs near that tumor to get this dose of radiation. And then the computer takes all that information in and does what's called an inverse planning algorithm to basically create a plan that accomplishes all of those goals that I've set forth. What happens is there's typically multiple different beam angles that are utilized, and then from every given beam angle, and what this picture is trying to demonstrate here, there's a completely different shape of the radiation beam, so that we're potentially carving off of some of the internal organs, but still targeting the part of the tumor that that beam actually sees. And what you end up getting is what's called a fluence map, which is described down here, where you can see a high dose of radiation to certain areas and lower doses of radiation kind of on the periphery. This allows customization based on those planning objectives that I mentioned, and is often the way we treat a lot of tumors nowadays. Here's just another example. I'm trying to depict what I was talking about. So this is a patient with a head and neck cancer. And each of these different angles here is supposed to represent a different radiation beam path. And the white and gray squares are supposed to represent the different intensity that that beam is projecting onto that area. And so you can see here that it's a very different shape in all the different directions. And what you can see here is the red here is supposed to be your tumor that we're targeting. The blue is also an area that we're targeting. but the green here is our spinal cord and our brain stem, and we're trying to tell the computer, hey, I want you to carve the dose off of that area and give a lot of radiation to where the tumor is located. Another type of radiation is called brachytherapy. And what this basically is, and as a general concept, is where we place a radiation source inside of a tumor or adjacent to a tumor. Brachytherapy, because we're delivering it through, I often tell patients this is called our internal radiation. It has a very rapid dose fall off, which allows maximal sparing of the normal tissues because there's no going through other tissues to actually get to where the tumor is located. And so this is commonly used in different body cavities, for example, cervical cancers, endometrial cancers, vaginal cancers, as well as some nasopharyngeal cancers in the head and neck. Or it can also be used for tumors that are close to the surface, like prostate cancer, sarcomas, tongue, lip, and breast cancers. And we'll show some pictures of that in a little bit as well. This is another type of brachytherapy, which are called eye plaques. So there are patients who actually get uveal melanomas, so melanomas in the eye. And often what we do in combination with our ophthalmology colleagues is we can actually sew a little radiation source in behind the eye to deliver some radiation to where the melanoma is located. It delivers radiation for a couple days, and then we take that out. And it's a way to give a very high dose of radiation to the tumor with a minimal dose of radiation to some of the other organs. Commonly for brachytherapy, what's really used in the modern day now is called high dose rate brachytherapy, as opposed to in the past what was called LDR or low dose rate brachytherapy. And essentially what this does is it's a safer way to deliver the radiation, both for the patient, radiation oncology staff, as well as hospital staff, where we have a unique treatment machine that can deliver radiation through catheters or applicators like this. It delivers a very high amount of radiation in a very short time frame. So typically these treatments only take about 10 to 15 minutes. Whereas in the past, before we had this type of technology, a patient would actually have the treatment over 3 days. So they would be immobilized in the hospital for that time period. And this is really how we now deliver radiation for cervical, for all the GYN cancers, as well as any other time really now where we're doing brachytherapy. Another unique type of radiation that has been around now for, I'd say, the past 10 years is called stereotactic radiosurgery. Well, stereotactic radiosurgery has been around for longer, but also SBRT, which I'll show you here. So stereotactic radiosurgery is basically using radiation with the same precision as a surgeon, or kind of knife-like radiation therapy. And this was historically used to treat brain tumors through a type of machine called the gamma knife. And basically what this gamma knife was is it was a machine that had 201 different sources that all converged on the same point to give a very high dose of radiation to the tumor with essentially a negligible amount of radiation through any one of those 201 beam paths. It's a very successful way to treat different types of brain tumors, especially brain metastases. And then because that technology was so successful, we've been able to create that and use that other places in the body, which we call stereotactic body radiation therapy. We often abbreviate that SBRT. And this is commonly used now to treat lung cancers, which is what's depicted here, liver cancers, as well as some bone cancers. And it's been so successful in lung cancer that they're actually now doing studies to compare doing surgery versus SBRT because the local control has been so high with that and so successful. One of the things I always like to point out, because this is often a question I get asked as a radiation oncologist, they'll say, well, are you going to cyberknife it? So cyberknife is actually the name of a type of machine that can deliver SBRT. I tell patients it's often like a brand name, but the generic name for that is SBRT. And that's just a type of machine to deliver this type of therapy. So a couple points on radiation biology. So when we give radiation to cells, whether it's in vivo or in vitro, basically what happens is you develop what's called a radiation survival curve, okay? And so if you give a very high dose of radiation or use densely ionizing radiation like particle therapy with neutrons or alpha rays, you get a very sharp, steep survival curve here where you can kill a lot of stuff in that one path with a lower dose. When we use sparsely ionizing X-rays, which is what's used therapeutically, you get a curve that looks more like this here, okay? And some of these different ratios talk about the different mechanics of how the cells actually die. Oftentimes with radiation, though, instead of just giving one large treatment, we give radiation over several days, often I'd say on average about 5 weeks. And so what actually ends up happening is instead of your curve looking like this, where if I gave one large fraction of radiation, you get a curve that looks a little bit more like this. And this is what we call the effective survival curve for a multi-fraction regimen. And the rationale behind doing this is that we're taking advantage of the slightly improved survival of normal tissue to smaller doses, and then we amplify that over many different treatments. And so what you can see here is that when we give radiation, we can have both early, what we call early responding tissues, as well as typically what happens with the tumor, as well as late responding tissues as well. And so the early responding tissues often will, and the tumor will respond to different doses of radiation than the late responding tissues. When we talk about giving radiation and radiation biology, we talk about the 4 R's of fractionated radiation. And so this is what happens to both normal cells, but also tumor cells when we give radiation. So one of the things that happens is when we give radiation, there's damage to the DNA. And our healthy cells are actually able to repair this DNA damage for the most part. Some tumor cells are able to repair some of this damage, but when we give the radiation over many days, over many weeks, the idea is that the tumor cells accumulate so much DNA damage that they ultimately will die over time. So a repair is one thing that happens. Additionally, when we give radiation to cells, there can also be what's called reassortment, and we'll show a picture about this in a second, where basically radiation can actually induce or cause cells to accumulate in certain phases of the cell cycle. Now, certain phases of the cell cycle are also more susceptible to DNA damage than others. So for example, when we're getting into the G2 and M phase, where the DNA is more condensed and coiled, the radiation damage is much more severe than when it's in, say, the latent phase and nothing's actively happening in the cell. Another concept that happens is called reoxygenation, where basically after radiation is delivered, a tumor cell might become slightly hypoxic for a short time, but then it can reoxygenate again. And what we know with radiation is that tumors that have hypoxic areas are less sensitive to radiation than tumors that are well oxygenated. This has been well studied in cervical cancers, for example, and it's actually an active study question still of how in cervical cancers do we get more oxygen to the tumor to induce more damage, and there's various drugs that have been tested to try to do that. And then lastly, repopulation. So even though we're giving radiation a little bit every day over several weeks, both tumor cells and normal cells can repopulate between doses of radiation. And so we always have to account for this when we're kind of creating our radiation plans and different types of tumors have different rates of repopulation. So starting with that first star repair, so again, the primary target of radiation is DNA, and there can be a couple of different effects of the radiation, both a direct effect of radiation, where if you give radiation, it actually directly damages the DNA and causes a double strand break. And these are the most lethal type of injury that radiation can cause. And then additionally, there's indirect effects of radiation, where basically radiation can form a free radical, and that free radical can then go and damage the DNA. But oftentimes the free radicals, when they do damage DNA, cause a single strand break. And these are very easy to repair for the tumor because they have their template right next to them. When we look at different types of radiation, photons as well as particle radiation like neutrons or protons or carbon ions, because they're a more bulky, they have more bulk to them and more mass, they can cause more double strand breaks than photon radiation can. And so that's one of the reasons that that's actively being studied as maybe a way to improve our cure rates for certain cancers. When we look at redistribution, as I mentioned, throughout the different phases of the cell cycle, when we give radiation, we can have accumulation in both the G1 at the G1 checkpoint, as well as the G2 checkpoint. Chemotherapies also augment this cycle a little bit as well, and so oftentimes we give chemotherapy in addition to radiation as a radiosensitizer to kind of help push cells into this G2 phase, where we know when we give radiation, the damage can be more lethal. And here's just showing a couple of the different pathways, specifically the ATM pathway, which is very important for radiation and double strand break repair, and how that can lead to, say, G1 arrest or total cell cycle arrest. As I mentioned, different phases of the cell cycle are more sensitive to radiation. So what you can see here is this is the curve for the mitosis and G2 phases, and you can see that the early synthesis and late synthesis phases are the least sensitive. Again, when we look at reoxygenation, so this is an example of a neuron here, and this is a picture depicting different areas of hypoxia. So very close to blood vessels, the tumor cells are often have enough oxygen, but as they get farther and farther from those blood vessels, they become more hypoxic. And these two different graphs here, what you can see is that there's a difference in the surviving fraction, whether it's hypoxic or whether it's well aerated. So well aerated tissue is able to respond to the radiation and have more damage much more than hypoxic tissues. In addition to this, there are different ways that we can modify the effect of radiation. So one of the things that we can do is try to give a drug or some sort of medication that might cause more tumor death at the same dose of radiation. So what this is supposed to show here is here's a curve of your tumor. Here's your dose of radiation, your percent of tumor control, and here's your normal tissue. And so if we give something called a radiosensitizer, we're trying to shift this line to the left. So if you're giving the same amount of radiation, you're getting increased local control with no change in tissue damage. So the most common one of these that we use is chemotherapy to do that. Additionally, there are other drugs that are called radioprotectors, where instead of shifting this line to the left, we're taking it to the right. So we're now able to give a higher dose of radiation with you having the same amount of normal tissue damage, but we're providing, again, potentially more local control. And these are both active areas of ongoing research. Radioprotection is a big deal, I think, with just bioterrorism, and I know some of that work is being done here at the NIH as well. So in addition, there are a lot of different targets that we can use for radiation. So there's single target agents like EGFR, VEGF inhibitors. Here's a whole bunch of different ones that you can see here. And generally, the majority of these different types of proteins are involved in some way, shape, or form with DNA repair. Additionally, there's different agents like chaperone proteins, so heat shock protein inhibition, altering your microenvironment through drugs like bevacizumab, which can change your angiogenesis, epigenetic modification as well. And then additionally, there are other antigens and receptors that can be radiation-inducible targets. And so, again, there's active areas of research in how can we combine these different types of things, targeting these different molecules to improve our radiation outcomes. So this is just one example of the EGFR family and how radiation can interact in many different ways. One of the things I wanted to point out is that for some of these different areas, you can see that there's already been approved drugs that have been created, as well as other drugs in active study. So drugs like Iressa and Tarceva are tyrosine kinase inhibitors. They're often used for patients who have lung cancer who have one of the EGFR mutations. Cetuximab is a very common agent used in head and neck cancers. Trastuzumab and now pertuzumab are also used in breast cancer and have had a very huge impact. Bevacizumab is another type of tyrosine kinase inhibitor, which is actively used in glioblastomas, brain tumors. So you can see that there's a lot of different ways we can kind of help target all these pathways, which are all at some point interrelated, and use them safely with radiation therapy. So when we're looking at issues for target and agent development, you always have to think about the mechanism. So what is the cell type that you're targeting, or is it something that's condition specific? You want to look at the method of how you're targeting these agents. So is it an antibody? Again, like the EGFR inhibitors, the VEGF inhibitors. Is it a small molecule like Gleevec, which is used in CML, as well as different gene therapies? I'd say the gene therapies have probably been the least effective, at least right now. Both of antibodies and small molecules have been very effective, at least today, in looking at how they target cancers and how they have an effect. And then you also have to always consider the therapeutic ratio between the tumor and the normal cells. So sometimes if the therapeutic ratio, if you remember those two S curves I just showed you, if they're very close, it's really hard to kind of move the curve one way or the other. But if they're farther apart, we can often have more of an impact. Another thing, and I got a lot of questions about this last year, so I wanted to touch on this, is that there's also an increasing body of evidence that immunomodulatory agents can be combined very well with radiation therapy. And one of the things that we've seen is something called the Abscopal Effect, which I'll show you on the next slide. But types of agents that have been shown to be important with this are PD-1 inhibitors and PD-L1 agents as well. And this has been, this made a lot of news back in 2012, specifically in this case report in the New England Journal of Medicine, where it was used with melanoma. And basically what happened in this study is there was a patient who had metastatic melanoma, so had multiple spots throughout their body. They were given one of these immunomodulatory agents, which harnesses the immune system, and one single site of disease in the body was given radiation through that SBRT approach I talked about. And surprisingly, what they found, and what's circled here, but is probably hard to appreciate from your seats, is that even though we radiated one site of the body with radiation, all the other sites actually responded and shrunk, okay? And so there's clearly an interaction now that's being actively studied, and this is a very active area of funding, of how do we harness the immune system with radiation to actually get an overall effect in the body. So just talking about radiation therapy in clinical practice. So again, one of the goals of radiation is to cure cancer, so cancer that's localized to one organ or region, and radiation is very good at that. One of the nice things about radiation too is that it's disease agnostic, meaning that with chemotherapy, there's only certain chemotherapies that work for certain types of cancers, but radiation can work on every type of cancer. Radiation is also often used for palliation. So when patients have cancer disseminated to multiple organs, radiation is often used to palliate those symptoms such as pain, or let's say someone has a lung cancer and their lung collapses, radiation can be used to shrink that tumor and open up the lung again. Radiation is also often used to palliate bleeding. So if a patient's having a lot of bleeding from a cancer, we can use radiation to make that bleeding stop and the patients no longer need transfusions and so forth. Believe it or not, about 50% of the patients that we actually treat in radiation actually fall in this palliation category because now that we have better chemotherapies, patients are living longer and develop these different sites of disease that cause them problems over time. So in terms of indications for radiation, when we look at cancers, what types of cancers do we cure? This is by no means a comprehensive list, but radiation should really be thought of being used when we're targeting solid tumors. So prostate cancers, other urologic cancers, breast cancer, lung cancer, head and neck cancers, et cetera. Radiation is not typically used for a lot of leukemias, although certain leukemias we do use that in, and is used also in lymphomas. And then again, for palliation, I talked about this as well. When we talk about giving radiation, radiation is almost never given in isolation. So patients are often given an oncology team. It's very rare that a cancer nowadays is treated by one single modality. And so oftentimes both medical oncology, surgery, or surgical oncology are all kind of converged to be part of the oncology team. But certainly primary care physicians, radiology, other interventional specialties, another huge specialty that we use now is called interventional. There's actually an interventional radiology oncology fellowship that's a very rapidly growing specialty. And then again, oftentimes patients and their families need social work support and other support services because cancer is usually not only a physical diagnosis, but also an emotional and psychological diagnosis for both the patient and their family and caregivers. So generally, anytime we see a patient, the first thing that happens is you often are developing a multimodality plan, which may include surgery, radiation, and systemic therapy like chemotherapy, hormonal therapy, or other targeted agents. And then sometimes we also combine some of these modalities with other localized therapy. For example, there are different interventional radiology techniques where we can focally ablate tumors through either heating it with ultrasound or freezing it with cryotherapy. And there's also different ways to give focal drug delivery. So for example, we can combine chemotherapy to different particles that we can use for the liver treatments called TACE. We can do the same thing with radiation. We can combine radiation to little beaded particles and give them to the liver, and the radiation beads just congregate around the tumor. So what happens in the radiation therapy process? So the first thing that happens is we as radiation oncologists see the patient in consultation. Often, at least where I think at larger hospitals and academic settings, there's often tumor boards where basically all those different people from the radiation team here are present. And we all talk about each of the cases ahead of time and come up with a general consensus and plan for that patient. Because again, oftentimes we have to sequence all these different therapies, and the order might change depending on the stage of the patient, their comorbidities, and so forth. Once we decide that a patient needs radiation, they undergo a CT simulation, which is called the planning session. And so basically every radiation oncology facility has their own CAT scan and or MRI scanner, where we basically will put the patient in the same position we want to treat them in every day. We create customized immobilization devices so that they lay in the same position each day, and also put marks on the patient, either through temporary marks or some places still use permanent tattoos that we use to line them up each day for treatment. We then take that information from the CT scanner and transfer that to the treatment planning system, okay? And all of this is actually done all within the same roof because all these different pieces and different steps are all kind of combined together through different calibration curves and so forth. Excuse me. We can also fuse outside images. Let's say a patient had a PET scan at another location. We can fuse that in the treatment planning system to help delineate where the target is. Once we go into the treatment planning system, what the physician does is they go into the treatment planning system and look at all those CT slices, slice by slice, and they draw our normal structures that might be affected by the radiation in that area, as well as all of our target structures. Once we're happy with that, we then have a special type of person called a dosimetrist who actually creates the radiation plan in the treatment planning system. Once that plan is created, the doctor then has to evaluate it and say, I like this, I don't like that. What are my doses to my normal structures? Am I getting the dose that I want to my tumor? And once the physician is happy with that plan, there's then actually medical physicists who then go in and check that plan and make sure that it meets all of our quality recommendations, all of our quality guidelines, that it's actually what we call a deliverable plan by the treatment machine. That plan is then transferred to the treatment machine, and then the patient undergoes the treatment delivery. This is an example of a slice from our treatment planning software. So this is a patient who has a head and neck cancer. They had what's called a floor of mouth cancer. The red line here that I'm outlining is our target volume, or what we call here it's called the postoperative bed, or our GTV, or gross tumor volume. What you see here in the yellow and the blue and then the pink and the green are areas of lymph node regions that we're targeting with the radiation. Here in the green here, you see the spinal cords outlined, and here is one of the parotid glands, and you can see over here on this sagittal slice here, the brain stem and the spinal cord as well. And so all of these things are contoured out for every single patient. Depending on the disease site, this process can take several hours for the physician, or sometimes it might take 30 minutes. All right, so moving on to some case presentations. So the first case that I wanted to discuss is a sample breast cancer patient. And so what we'll kind of go through and walk through is developing a treatment plan through a multimodality approach, determining the appropriate radiation modality, how do we identify the target, how do we identify the surrounding normal tissues at risk, then creating a treatment plan, delivering the plan, and following the patient. So this patient is a 55-year-old female who found a new lump in her left breast. She had a mammogram performed due to the abnormality, which did confirm that there was something on the suspicious on the mammogram. The patient ultimately underwent a biopsy, which was consistent with the most common type of breast cancer, or infiltrating ductal carcinoma. And importantly, even though this patient is on the younger side for breast cancer, she had no family history of breast cancer. So the first thing we would do is develop a treatment plan, okay? And so for breast cancer, there's always, at least at this point in time, surgery is always a component of that. And so surgically, the patient could undergo a mastectomy, or removal of the entire breast, or undergo what we call breast-conserving therapy, which would consist of a lumpectomy, where we basically remove the tumor plus some normal tissue around it, followed by radiation therapy. And there were some important studies done now with over 20-year results, which basically showed mastectomy, and in early stage patients showed mastectomy to be equivalent to breast-conserving therapy. As we mentioned, one of the goals of therapy is to maintain function and cosmesis, for example, in breast cancer, and I think we can all agree that this picture here is rather morbid, but if a patient can keep her breast and receive the same cure with keeping their breasts in a good cosmetic outcome, that's preferable for many patients. Here on the right, we're just showing a couple different types of mastectomy. So radical mastectomy, what was called the Halsted mastectomy, which is really no longer used anymore. Here they actually removed the pec muscle. A modified radical mastectomy, which is still used today and is the most common type of mastectomy. And then lumpectomy, where here the black is supposed to simulate your tumor, and you would basically just cut out the tissue right around there. So this patient, like many women nowadays, opted for breast conservation. There are certain things that we have to look at to make sure a patient is a candidate for breast conservation, but the majority of women are. And the patient underwent a lumpectomy as well as what's called a sentinel lymph node biopsy, where basically before the surgeon removes the tumor, they'll inject technetium as well as a blue dye, which will then drain into the lymph nodes. They then are able to find the lymph nodes that drained the technetium and the blue dye at the time of surgery. And we typically remove anywhere from 1 to 3 of those lymph nodes, and those are called the sentinel lymph nodes. At the time of her pathology, when it was reviewed, it showed a 3-centimeter tumor and 4 axillary lymph nodes that were positive for disease. Generally, anytime a patient has any axillary lymph nodes that are involved, that's a sign or a risk factor for distant disease or potential metastases down the line. So this patient received chemotherapy, which would be in the standard of care. The most common type of chemotherapy now given for most patients is adriamycin, Cytoxan, and Taxotere. And then the patient returned to radiation oncology after completing their chemotherapy. So part of our job as a radiation oncologist is we have to determine, well, what type of radiation do we want to deliver for this patient? So would we want to give an external beam approach, which could be done with proton therapy, photon therapy, or electron therapy? Or is this patient a candidate for some sort of brachytherapy through either sealed sources or unsealed sources? And this is just an example of what's called an interstitial implant, where basically each of these white lines here in red and white, each of these is a catheter going through the breast. And then through these catheters here, these are hollow, we're able to deliver radiation therapy. This is not commonly done or as commonly done anymore because as you can imagine, it looks kind of painful and morbid. It actually has great results, but just because of the logistics of the treatment, it's not done as much anymore. Once we determine the type of radiation, which often in breast cancer patients is external beam radiation, we then have to target our volumes and do our planning session and then create our radiation fields. And so often for these patients, we have them laying on their back with their arms above their head. We put external markers on them. So these little white dots are all external markers here, which we use to index the patient so we know exactly where they're sitting on the treatment table. And then we have to create different beam arrangements so that we can target all the tissue that we want. So in this case, the patient is receiving radiation to the breast tissue through what's called a tangent field here. So this purple is actually representing the angle of the beam. And then this yellow here is actually representing what's called a supraclavicular field, where basically we're targeting some of the lymph node regions. And you can see it's kind of hugging the collarbone here. We then create the radiation plan. And so what you're seeing here is, so here's this red is one kind of tangent beam and the green is the other. And then we tell the computer to actually show us what the dose is. And so these different colors here are what we call isodose lines, and they show how the target is being covered with the radiation. What we're looking at generally is this red line here, which is called the 100% isodose line. And we generally want to see that that's targeting everything we want it to target. And then that we have what's called rapid dose fall off. And so here, for example, with this being a left-sided breast cancer, we want to avoid the heart. And so we can see that pretty much all the radiation is falling off kind of before it touches the heart or as it skims the heart. Once we've created the plan, as I mentioned, we then deliver the treatment. And as I mentioned, the radiation is delivered generally over several what we call fractions. So patients come on consecutive days, Monday through Friday, for several weeks in a row. Every type of cancer has a different dose of radiation that we give that's been shown to be effective. For breast cancer nowadays, we have something called the short course of radiation, where often we can finish the treatment in 3 to 4 weeks, whereas 10, 15 years ago, we gave what was now called the long course of radiation, which was 6 weeks. Additionally, each day as we lay the patient on the treatment table, We also take X-ray images to make sure that we're lining everything up the same way each day, or at least once a week to make sure that for quality assurance purposes. And so what's being shown here is what's called the port film, where basically this yellow square is actually what the size of the beam is, and the blue here are different collimators in the head of the machine. And this is the shape of the radiation field of what we planned in the computer. And then here on the right is actually the shape of what's being delivered on the patient, and we want these to essentially match. So the next patient is a 54-year-old male who had an elevated PSA on routine screening exam. The patient has had no prior medical problems, and he's sent to a urologist and has a biopsy, which reveals what's called a low-risk prostate cancer with a Gleason score of 6. So again, when we talk about developing a treatment plan, the patient might see multiple different types of physicians, and so surgery could be an option for this patient, surgery and radiation if the patient underwent surgery first based on certain pathologic findings. Radiation alone could be utilized, and there could be a whole bunch of different types of radiation, so brachytherapy, external beam radiation, or a combination of the two for certain patients, or radiation and hormonal therapy. So hormonal agents are often used for advanced prostate cancers. So this is an example of a prostate seed implant for one of my patients that I did last year. And so basically what you can see here is that, it's again hard to see, but this red kind of circular line overall is the shape of the prostate, okay? And then each of these little green dots represents where we placed a radiation seed within the prostate, directly into the prostate. And then what you can see here is the different dose of radiation that's now targeting over the entire prostate, and we want to see that you have this kind of yellow and blue lines that are kind of surrounding the entire prostate. And so you can see when we do prostate seed implants, we're putting many seeds in the prostate. Usually it's somewhere between 50 to 80 seeds, depending on the size and the shape of the prostate. It's not just, say, 1 or 2 seeds. The other thing you can appreciate here is that this green circle here is the urethra, which runs straight through the middle of the prostate. And so you can see that the radiation dose, this green here, is actually being carved away very nicely and protecting the urethra, which is something we can achieve with brachytherapy but can't do with external beam radiation. This is an example of a IMRT plan for prostate cancer. And so the red here is the prostate. The blue is kind of what we call our safety margin. So we have to account for the fact that the prostate can move each day due to bladder filling and rectal filling. So we have to account for that to make sure we're always targeting the prostate. And you can see that there's dose fall off kind of as we go out. This yellow here is the bladder. I'm protecting the bladder very nicely. For prostate cancer in particular, we also do something that's called image-guided radiation therapy, which we also use in some other sites. And so in the prostate, because we know the prostate can actually move up to 1 centimeter or 2 in any given direction due to bladder and rectal filling, we often implant markers into the prostate, either gold, what we call gold fiducial markers, or we can use something called calypso beacons, which are radio frequency beacons. And we have a special type of platform that's put over top of the patient here, as you can see here. And it can actually track where the prostate is in real time while we're actually giving them the radiation. So if, for example, the patient had a big air bubble in the rectum and that's released during the treatment and the prostate shifts by 0.5 centimeter or 1 centimeter, we can actually stop the radiation beam and reassess the patient. Or there are certain technologies where the machine actually might move so that the prostate can still be irradiated and we can account for that motion. So this is just a picture here of these gold fiducial markers from one of our patients. So you can see in green here, and it's circling kind of a higher density item. And so what we do each day is before the treatment is delivered, this is what was planned at the time of the planning session. This is the patient on the day of treatment, and we can actually align the prostate based on these 3 gold markers by triangulating them. Another thing that we have the technology to do is something called a cone beam CT, where basically our treatment machines have the ability to do a mini CAT scan on the treatment machine. And so oftentimes we use this in prostate cancer, for example, to check a patient's bladder filling to make sure that the bladder is kind of pushing the intestines out of the way. And so what you can see here is this is actually the patient at the time of our CAT scan. And then it's really hard to see, but there's actually a box that I'm outlining here, which is what we're actually seeing that day on the patient. And what you can see here from this view is that today the patient's bladder is not very full, whereas at the time of the planning session, this yellow line, the bladder was much more full. And so that's important because we want to push the intestines out of the way and decrease radiation dose to the intestines. So once the patient's aligned each day for treatment and has the appropriate imaging, we then deliver the treatment. And this is just an example of a prostate patient laying on the treatment table. So then the question, is it all really just that easy? Does all the cancer always die with the radiation? Are there side effects from radiation? And so again, we do know that there are some side effects from radiation. There is some normal tissue toxicity. And when we talk about radiation, we generally divide those up into both short-term side effects that happen during the treatment, as well as long-term side effects that might happen years down the line. Some of these different effects are due to stem cell depletion, chronic oxidative damage, can be due to vascular destruction, fibrosis, and other things. And again, the important thing to hear is that radiation is really dosed to the highest dose that the normal tissues can tolerate. It's not always dosed to the highest dose that the tumor needs, okay? We're often constrained by causing damage to normal tissues, and we always want to keep that risk to less than 5%. So just a couple of different examples of some of the toxicities with radiation. So one of the long-term toxicities is lung fibrosis. Again, this is an active area of research and how we can potentially protect that organ by a radioprotector. It's also an active area of research when it comes to kind of bioterrorism effects. And so we know from a lot of research now that there's a molecule called TGF-beta that is responsible for patients developing lung fibrosis. And so there's different groups that are looking at, well, how do we augment this TGF-beta expression to decrease the risk of lung fibrosis? And so this is an example, again, just to point out, this is from 1992, so not something that we do anymore. But this is an old lung field that was given, and what you can see here on a CAT scan is the patient has all these white tissue changes, which are consistent with radiation fibrosis. And what you can see is it's exactly in the shape of that radiation field, okay? Another example in breast cancer is the risk of lymphedema. This is also, and this is essentially due to blood vessel scarring and some damage that can happen as a result of radiation. This vessel damage is also kind of the reason why men who have prostate cancer can sometimes develop erectile dysfunction from radiation. The good news, at least on the prostate cancer front, is that different drugs like Viagra and Cialis, how they work is by allowing those blood vessels to dilate more. So at least in erectile dysfunction, we have a way to kind of fix that. But certainly in breast cancer, there's not always a way to kind of fix that. And this is just a picture kind of depicting what happens. But basically, you get some scarring of the vessels, which increases the pressure. And so the fluid of the arm is not able to drain as well. Another common side effect in head and neck cancers is mucositis, which is essentially due to stem cell depletion. So what you can see here is there's all this kind of white coating on the tongue here, white here, which is what mucositis looks like. Essentially, we tell patients this is like having a sunburn in your mouth. So as you can imagine, that hurts the patient. It causes discomfort. We can manage that with medications like lidocaine rinses and so forth, but oftentimes it affects patients' ability to eat. And so these types of patients often lose a significant amount of weight during the course of their therapy, which we manage. So where do we go from here? So radiation has really evolved very significantly, and I could probably add like 3 or 4 more different pictures on this slide now, from the 1960s when we developed our first LINAC to today. In terms of the future of radiation, kind of looking at the different areas, I think one of, again, the areas of active research is how do we combine biology with radiation? So how can we use radiation to induce targets for other agents? How do we make better radiation sensitizers and radiation protectors? And very importantly, how do we combine radiation and other targeted drugs, especially these immunomodulatory agents? In terms of radiation physics, we're always looking at how can we improve the targeting of our tumors, as well as the imaging that we're doing each day before treatment, and how can we improve our delivery method? So how can we maybe shorten time so that we can treat a patient in half the amount of time that we currently do? How do we give a higher dose of radiation with a shorter fall off to the normal tissues? And then clinically, how do we translate some of these laboratory findings that probably many of you are involved in into the clinic? And how do we continue to develop physician scientists? So some of the newer modalities of radiation are some of these radiopharmaceutical agents. So here's a whole list here. Some of these are used, the Zevalin and Bexar are used in lymphomas, for example. But there's a whole bunch of other ones that are in development. We have ones that specifically target liver tumors with yttrium-90. This is an example of a cyberknife machine, which has a robotic arm, so it can basically move in any direction for the patient. This is what proton beam therapy looks like, and it has something called a Bragg peak where the radiation beam can actually stop. I'll show you another picture of this in a second, instead of having this tail from X-rays. So can we use proton beam therapy to better protect our normal tissues while escalating dose to the tumor? So here's another example of that. So with proton therapy, you get this sharp peak called the Bragg peak, and so we can basically give the tumor a very high dose of radiation, and then there's a very short tail and fall off. Whereas again, X-rays don't stop, and it's really this kind of radiation out here, these lower doses, that we can change with proton therapy. We think that this is very important, especially for pediatric patients, where the less tissue we can expose, the better. This is an example of a difference between proton beam therapy for the heart compared to our conventional X-ray therapy. So this is a woman with a left-sided breast cancer, and what you can see, the red is the 100% amount of radiation, and the green and blue here are the 50 and 70% doses. And so what you can see is we're giving much less radiation dose to the heart with proton therapy compared to photon therapy. And then what might be very hard to see is there's these gray circles here, and these are actually the coronary arteries. So with proton therapy, we're actually completely avoiding some of the coronary arteries, and that might lead to better cardiac morbidity for these patients down the line. This is just a subtraction image of that. So as I mentioned, we actually do have a proton therapy center now in Baltimore that is run and staffed by our department. We've actually worked with some of the clinicians here at the NIH for a lot of patients, especially our chordoma patients. And so this is a new technology to the area. And essentially kind of all of that radiation biology work that I showed you at the beginning all kind of needs to be redone with proton therapy as well. So I think some of the take-home messages is that radiation is a very effective tool that can be used in cancer therapy. The way radiation works is by causing DNA damage, which then ultimately leads to cell death. The effects of radiation can be altered by modifying physical factors, physiologic factors, fractionation, drugs, and a lot of other variables. Radiation can cause complications, many of which we can palliate kind of in the short term, but there are some long-term complications that can still happen, and then also that radiation is interesting. So any questions? Go ahead. So great question. So the question was if there's ever any secondary cancers as a result of radiation. So radiation certainly can induce secondary cancers down the line, and that's essentially due to the fact that normal tissues can sometimes accumulate these lethal mutations as a result of radiation. Generally, we say the risk of that is about 1 in 10 to 20,000 patients, and it's not a risk right now, but it's usually a risk 10, 20 years down the line. So it's something that we talk a lot about for pediatric patients and young adults, because certainly we want those patients to live longer. And so, you know, for different types of cancers, we're always looking at, well, how can we reduce therapy? Is it with less chemo? Is it with less radiation, omitting radiation? And so that's always an active area of research. Again, for pediatric patients in particular, that's one of the reasons why people really like proton therapy, because it overall exposes a lot less tissue to radiation and these lower doses of radiation. And when we look at secondary cancers, it's what we call a stochastic effect, meaning that there's no dose at which it might not happen. So for some types of side effects with radiation, we know it's not going to happen unless you exceed a certain dose. But when we talk about the risk of secondary malignancies for patients, we think it can happen really at any dose, even these low doses. Now, I always like to point out chemotherapy can also cause secondary cancers. It's usually not talked about as much, which is okay. But certainly people develop myelodysplastic syndrome from chemotherapy, need stem cell transplants. There's other leukemias people can develop. But again, it is an effect that does happen. And again, we tend to worry about it more in the young adults and pediatric patients. Yeah, good. Great question. So the question is, how do we select patients to maybe undergo proton therapy compared to photon therapy? So I think this is an active area of, controversy in the country because of the cost of proton therapy centers. And so I think there's certain disease types which have very clear indications from data that proton therapy can lead to decreased side effects. So again, pediatric malignancies, chordomas, which are tumors of the skull base, where you're very limited with the amount of radiation because of the proximity of the brainstem. But then additionally, we also look at a lot of other factors for different patients. So we look at age, so if it's a younger patient, they might benefit more from proton therapy than someone who's older, in their 80s. We also look at patients' comorbidities. So for example, I have a breast cancer patient who's under treatment right now who's on oxygen. She has really bad lungs. She has really bad heart. And so giving her proton therapy decreases a lot less of her lung and her heart to radiation, which is really important for her because her overall medical status is pretty poor, whereas someone who's otherwise healthy, it would have a minimal effect. And then additionally, at least what we do at our center is if we're not sure, we'll actually do a comparison in the computer. We'll do a photon plan and we'll do a proton plan. And if we don't see a difference or potentially a tangible difference for that patient, then we don't give them that therapy because it's a scarce resource and we want to make sure that we're giving that to the appropriate patients. It's a great question.
Okay, thank you. That'll do it.
Yep.
Our next speaker is Anton Simeonov. He got his Ph.D. from the University of Southern California. He did a postdoc at Concordia College, and then he joined NIH in 2004. He's worked at the NCATS, and he's now the scientific director. The title of his talk, Processes and Improvements in Small Molecule Translation. Anton.
Thank you, Terry. I'm glad to be here. This is my third or fourth time giving the TRACO lecture, and it's getting more and more difficult every year because, you think you've got your slides ready and you always decide to change them last moment to add new stuff and change topics and bring something fresh into the picture. So I'm going to try to actually give you an overview of latest things that we're doing within the center. So bear with me. There is really some forward-looking stuff. So translation at NCATS, we view this as the process of taking a basic discovery made in the lab or clinic and developing this discovery into a tangible intervention that improves human health, whether it's therapeutic intervention with a drug, whether it's a procedure, diagnostic test, device, you name it. Or to put it differently, what prevents all these great discoveries in the biomedical field published in Science and Nature from becoming actual treatments? Very few of them do. There are a lot of papers in every issue of Science and Nature, and in the end, every year you see very, very few new drugs or other interventions. So there are a lot of problems in this translational space. I'm highlighting a couple of these, and I'll talk about the first two especially. We don't have good predictive models for efficacy for testing of toxicity of drug candidates, but to give you actually a very sort of distant example, within the clinical space, it's estimated that approximately half of the clinical trials in this country, the ones that are initiated, fail to reach completion. About half of them fail to reach completion because of inadequate enrollment. So imagine the amount of resources wasted on imperfect enrollment. So this is an example of one problem. It may seem to be a very boring problem, very boring detail in this whole process, but if you can solve it, you'll lower the cost of drugs. I mean, simple as that. So at NCATS, we're working on a lot of these problems, and I'll be giving you examples in this talk on how we try to improve processes of translation as relates to small molecule drug discovery. So really a very small subset of all these problems that are really facing us in this space. And you notice the word scientific is highlighted. There are organizational problems within the translational space that I'm not going to be talking about, such as public-private partnerships, ways to deal with IP, licensing, and so on. So these are organizational problems. So when you think about the drug discovery process, one starts with the question of where to intervene, what to intervene on, and there's the notion of drug target. Essentially, you try to perturb a pathway or isolated protein, modulate its activity up and down depending on the biology, and by doing so, you hope to achieve therapeutic effect. So in order to actually do this and test it in humans at the very end of this process, you need to traverse this whole path along with the associated risks and costs that go up. And that's why in the end, you end up spending on the average of $1 billion or more on a new drug. So we're focused on various steps of this process and how to improve them, right? So that we can make the overall process more efficient. So initially, when you have a target, you need to identify traditionally small molecule chemical matter that perturbs the target. Then you go through a process of optimizing this chemical matter to reach a drug candidate. So you do a lot of chemistry optimization on the molecules, modifying them to improve their properties. Eventually, you test them in various preclinical models, whether it's animal models, you evaluate their toxicity, essentially their goodness for testing in humans, and then one day you hope to proceed with actual testing in humans. So I'll be giving you various examples of processes along the way and how we go about improving them. One thing to stress on is translation is really a team sport. Every project that we have is collaboration with somebody on the outside, because you can quickly picture this process where in the science paper you will have a finding that originates from deep expertise in a particular biological problem, whether it's particular gene, pathway, physiology, disease, whatever. But there is very little knowledge within that initial team of how to develop the intervention. Essentially, knowledge of what to do as far as these steps. So this is why translation requires both areas of expertise, the knowledge about this process and the knowledge about disease or biology. So by necessity, every translational project is a collaborative project. It's a team effort, really. And you'll see examples to this effect later on. So to discover small molecule modulators of various targets and pathways, we employ a range of these screening assays to test the candidate chemicals. We have the ability to test systems in very reductionist format, that is isolated proteins, looking for, say, inhibitors of enzymatic activity or protein-protein interactions, using essentially purified biochemical-based system, and then going up in complexity level, we can interrogate pathways through various reporter enzymes, fluorescent labels, and so on, all the way up to looking at various phenotypes. What happens to the shape of a cell? What happens to an organelle? Is protein being trafficked from lysosome somewhere else or exported out of nucleus, and so on? There are various systems that we have available at our disposal to measure all these changes and quantitate them and essentially do it many, many times over in highly reproducible manner. So how do we do this? We actually employ 1536 well plate technology. So this allows us to miniaturize assays to an incredible degree, really. you can imagine traditional 96-well plate, and I'm sure you're familiar with 96-well plates running ELISA assays and whatnot. One 1536-well plate contains the equivalent of 16 96-well plates. And of course, you have to reduce the volume of your assay in order to fit it in these plates, thereby achieving enormous savings in reagent amounts and allowing you to really ask different types of questions at the scale. So you can see a very simple math here with traditional 1536-well plate. You can reduce the time it takes to screen about 1 million samples dramatically to just a couple of days, depending on the protocol. So you can test more compounds or ask different questions, as I will show in a second. So all of this is done at NCATS utilizing highly automated robotic systems. It's always cool to look at these orange arms and actually visit the lab where these screens are run, and especially when the arms are moving. It's a pretty incredible sight. So we've had this system shown graphically here for the past 11 years and have run well over 150 large-scale screens and around 200 additional smaller-scale screens. So it's been running pretty much 24/7 over the past decade or so. You can imagine the orange arm as being a technician of sorts. They approaches a plate, scans its barcode, picks it up, and moves it from workstation to workstation. And then the various peripheral units perform the various steps involved in building an assay reaction, such as dispensing reagents into an empty plate, performing various incubation steps, adding the small molecule drug candidates, and then taking all sorts of measurements and feeding the results into a database where informatics processes are applied to calculate the data. So, so this is high throughput screening. So how did we improve that process, right? I started by saying that we try to improve the processes in order to make everything more efficient and drug discovery faster, cheaper, and more reliable, less risky. So one thing we did a couple of years ago, actually, at the beginning of this effort, was to recognize something very obvious: the fact that high-throughput screening is traditionally practiced by testing each molecule at single dose. People have been doing this for several decades. They just pick, say, 10 micromolar concentration and apply the entire library to the test at hand, not varying that concentration at all. And then they apply various statistical cutoffs and pick up active hits and proceed from there, experiencing quite a bit of noise, false positives, false negatives, and all that. Wouldn't it be nice if we could adopt something very obvious, which is to test every substance at multiple doses? After all, different molecules have presumably different potencies against particular target or biological process. The dose is what makes a drug and also what makes poison, right? So we did array the library, as shown in this cartoon here, as serial dilution from plate to plate. So every plate here shows the same library of molecules, except they exist in the different plates at different molar concentrations. So very different from performing serial dilution the traditional way within a plate, where you would just do serial dilution left to right or down the column. Diluting from plate to plate actually gives us enormous flexibility. We can skip concentrations if the assay is very expensive or the protocol is complicated. We can repeat certain tests if plate fails by rerunning it, and so on. So with these compounds over 7 to 15 concentrations, depending on project needs, over 4 orders of magnitude, really spanning single-digit nanomolar all the way to high double-digit micromolar, close to 100 micromolar top concentration. So really the traditional range of activities of small molecules. And these assays are run at very low volumes, as I mentioned, typically 2-3 microliters, no more than 6-7 per well, building these assays using these automated liquid dispensers. We developed dedicated informatics pipeline to analyze literally hundreds of thousands of those responses, fitting them to the Hill equation, looking for outliers, classifying curves, delivering IC50s in the cases of complete responses within the time span of 20-30 minutes. And then to that, we add a little bit of time manually curating curves that are flagged as uncertain. And literally within less than a day, including the manual work on data triaging, you have a data set of, say, 2 to 5 million data points on 500,000 compounds, all tested in dose response. So this leads to really nice pharmacological profile for every molecule. You can see the shallow curve, if there is such, and that happens in some hormone receptor type assays where you have a reproducible effect that is not 100% from top to bottom, and it has biological meaning. If you don't test your library in multiple concentrations, you're not going to catch such an effect. You also dramatically reduce false positives and false negatives. So this is what we did to improve the process. We provided not only the data and general description of the process in publication, but we also provided the source code for analyzing the data and the exact algorithm for how to make the library and essentially run the screen so that people can reproduce it. On the chemistry side, we have a full-blown chemistry operation that is coupled with analytical chemistry and in vitro toxicology assessment. When we talk about chemistry, it's very easy to overlook what this entails. It doesn't entail just making a bunch of analogs of the original hit molecule with the goal of improving potency, as shown here. There is effort, simultaneous effort to improve the pharmacokinetic properties of the molecule. A molecule may be a nanomolar binder. In this case, I'm giving you an example of ubiquitin-specific protease 1. So really the first in kind small molecule, highly selective inhibitor of USP1 designed to test protein deubiquitination and its regulation in the cell. You're also trying to prepare the molecule for testing in vivo, in animals and humans. And for a molecule to be testable in vivo, it cannot just be potent against its molecular target. It cannot just be selective. It has to be soluble enough. It has to be stable in blood. It has to have enough half-life, bioavailability, and everything. So all these metabolic clearance properties have to be optimized to chemistry in parallel. So medicinal chemistry, in fact, is not an isolated process. The compound is synthesized, purified, characterized, data in parallel are generated on the new molecule, its structure, it has to be registered in databases. Its analytical data has to be appended to the compound file, and then data on its biological activity has to be generated along with other properties such as solubility, plasma stability, stability in the presence of cytochrome P450 and other major metabolic enzymes. So it's actually a highly integrated effort involving not just chemistry making molecules, but integrated testing, analytical characterization, and everything else. So back to learnings, what we're doing in this space involves a lot of lessons in screening, in novel assay design, in dealing with false positives, developing novel informatics processes. We try to disseminate this knowledge as rapidly as possible, not just in the form of peer-reviewed publications, but actually creating a portal that is dedicated to this early discovery space, and we're doing this through this e-book on the NCBI's bookshelf called the Assay Guidance Manual. So this started about a decade ago through a collaboration with Eli Lilly, the big pharmaceutical company, which had this in-house manual that was essentially designed to teach their internal staff to develop assays, set up screens, run informatics analysis on the data. And after a lot of interactions back in 2005, we were able to convince the Lilly legal team to release this internal manual into the public domain. And then we assembled a large team of experts to contribute new chapters, rewrite old chapters, and really keep updating this book to reflect what's new in this field of translation. For example, incorporation of stem cell-based models in preclinical testing and other analytical techniques. And you can access the manual on the web. Usage has been going up steadily, and that's another way of advancing translation and translational science by really rapidly disseminating all new findings and serving this educational function in addition to just conducting various projects in the space. So I mentioned the need to improve test models and what we're doing in this space that is really most current and recent and upcoming. We need to improve test systems to improve predictability. A lot of drugs fail because they're developed to hit the target, but the test methods used for validation have been very primitive, for lack of a better term. And even in high throughput screening space, we've been confined to these simplistic models of 2D cultures, immortalized cell lines, HEC293 based test systems, HeLa cell based. The future is really in stem cells, using human-derived cells differentiated into specific tissues that best represent interhuman variabilities and represent really the closest approximation to primary tissue that you can get without having to harvest organs and create test systems out of actual primary cells. So to this end, we're actually starting a stem cell translational lab at NCATS where there are several key goals in this field. We're having actually multiple goals around the stem cell lab. One is to standardize the field, provide better ways to characterize induced pluripotent stem cells and final differentiated cells in order to standardize protocols and really reach common standards in the field where if somebody claims that they've made mature cardiomyocytes from an IPS line, that they actually provide universally acceptable set of criteria, test results that actually verify that they've made final mature functional cardiomyocytes. This is not the case right now. People publish based on essentially 2-3 markers, little flow cytometry study, and they declare victory. And in the end, when others attempt to use those cells for regenerative medicine therapy, turns out the cells are actually not mature or not fully functional. So we're trying to essentially standardize this field and create QC standards. Along the way, we're also going to be running small molecule screens to discover small molecule reagents that are cheap, reproducible, scalable, that can be used to replace expensive protein factors, animal-derived media components in order to make IPS differentiation protocols dramatically cheaper and more efficient. This is a huge barrier in this translational space that prevents really more regenerative medicine clinical trials from being started. You simply cannot make enough cells to then inject in the patient and achieve that therapy, whatever the therapy might be. So making these protocols literally 100 to 1,000 times cheaper is a key goal here. demystifying the field and making these protocols cheaper, transferable, scalable, so they can be used for regenerative medicine purposes. And one way to do is to find cheaper reagents. Also, when you improve such differentiation protocols, you can imagine taking cells from patient with a particular disease and then building a disease model with the scaled up cells and running high throughput screen to discover therapeutic candidates for that disease. So all these go hand in hand. So this is all very easily said, but very difficult to do, because how do you actually combine this robotic system with the reality of protocol like this? And this is not meant to be read in detail, but here is an example of IPS differentiation protocol, actually from campus here. This is from Kapil Bharti's lab at National Eye Institute. They're actually working on cell therapy for advanced macular degeneration. It's an autologous graft where blood cells from the patient, they're selected CD34 positive cells, turned into IPS clones, and then differentiated after scaling up, differentiated into retinal pigmental epithelial cells. Extremely long protocol. This is what we're trying to improve, taking all these different steps of media exchanges, selections, addition of reagents, and running high throughput screens along the time axis of differentiation to find replacements of expensive reagents, to find small molecules that would accelerate various steps or improve the cell yield. So it's a very difficult challenge, actually. It can be done. This is an example of producing astrocytes for disease models. They're very important major neuronal type. And guess what? We had different intentions for astrocytes to use them in various neurodegenerative disease models and screens, but Zika happened. And so we ended up using astrocytes in Zika screens. And if somebody tells you you can get a Nature Medicine paper out of a high throughput screen, don't believe them, except in cases where you have Zika in the title. Really, what counts here is speed, not how to say whether you've moved the field, because if you read this paper, you will see that it only covers screen and very basic initial characterization of molecules. But in the case of public health emergency, this is what counts. You want to move these molecules out of your lab and into the public domain as quickly as possible, because really the currency here is not how long I'm going to be hoarding my data and developing my results. The goal is to actually disseminate the results and let the community pick up these molecules in whatever shape or form, whether through partnerships with other NIH institutes or with help from other organizations, and actually turn them into interventions. But it's an example of stem cell-derived final, in this case, astrocyte neuronal type cells that were used as the host cell of Zika virus infection following the host cell death by looking at caspase-3 activation as a marker of cell death. So for a lot of these projects, both treating diseases and improving stem cell differentiation protocols, we recognize that we're going to need combination of reagents or drugs. With the differentiation protocols, there are multiple protein factors and media components working together. In a lot of diseases, there's benefit in using 2 or 3 drugs simultaneously. So how do you go about improving the process of finding novel drug combinations rapidly, efficiently? How do you do drug combination screening in high throughput? So it obviously starts with having a library of approved drugs, and we've assembled at NCATS with, or arguably, the largest libraries, most comprehensive libraries of both approved drugs that have been marketed for particular indication or are being currently marketed, as well as investigational agents. That is, things that are being tested in humans, but that have not yet been approved for actual use. We need a process to mix these molecules and test them at various concentrations, in this case showing pairwise combinations, and then automated platform to analyze that data. So we're doing this by running first a 6x6 matrix of drug A tested against drug B in custom dose response ranges based on knowing what they do as single agents. So for example, if drug A is micromolar potency and drug B is nanomolar potency, it doesn't make sense to test them in the same molar concentration range. You need to custom tailor A versus B, knowing that one is less potent than the other. So the only way to do this without spending years on one screen and breaking the bank using excessive amount of consumables and reagents is to use this modern technology of acoustic dispense. This really came online the past 3 or 4 years. Didn't exist this technology before. What happens here is essentially pulse of acoustic energy is applied to liquid contained in this microtiter plate. A droplet of picoliter size gets ejected upwards, flies up and lands on the bottom of a recipient plate that is turned upside down. You can repeat this process at very high frequency many, many times over. The system knows the volume of each droplet ejected based on the fluidic properties. Because the droplets are so small, there is no splash. They just land and form small film on the surface of that recipient well. And by counting the number of droplets, you can deliver very precise volume, say 21 nanoliters or 311 nanoliters, without using any pipette tips, capillaries, consumables, and at the same error of volume dispense across very wide volume of a range of volumes delivered. Because again, you're counting droplets, that count is precise, and the error of each droplet's volume is constant. So you're not propagating errors in the far out ranges of the volumes delivered. So you can do this, and we've practiced it probably over 60 times on various projects. This is one of the first projects we use this process on. And the reason I'm showing this paper is not just because it's related to oncology, but this was really the paper where we not only provided the data and the data browser, but also the acoustic dispenser source code and all the analytical procedures to allow others to replicate this process. Again, in translation, at least as far as NCATS is concerned, the goal is to disseminate, not just to make an advance, but to disseminate and not to keep anything private and proprietary. Because really the goal is to help all boats rise. You know, who cares about one specific example if you can't really move the field forward? So we're trying with all these publications to not just provide nice example of this process improvement, but to actually help others improve their processes as well. Again, a recurring theme here. So moving right along, we're trying to adopt stem cell-based models, but there is another aspect to improving models, and that is introducing the 3D component in this whole picture. The very simple 3D models are referred to in many fields as 3D spheroids. There are a lot of examples where you can essentially dispense cells in different types of plates and let them aggregate one way or the other, and they form these clumps or spheroids, and they represent better model of solid tumors. You can go one step further and actually have specific layering of multiple cell types, one over the other, to build essentially a tissue support layer and then something else on top of it. And then you can also do 3D bioprinting of defined tissue types. So we have done quite a bit in this space. So this is just one very brief example of ovarian cancer model. It was published over a year and a half ago. We do see feasibility of not just building this model, but building it many, many, many times over reproducibly in 1536 well plates, and being able to use it to screen large collections. So this is, again, important, not just creating it once and never being able to reproduce it, but really running this thing in production mode. The next stage of this effort is bioprinting. We're collaborating with at least one company, Organovo in this case. They're based in San Diego. This is a case where literally using a 3D printer in conjunction with specific hydrogel type polymers. You suspend the various cells in those polymers and you deliver that suspension in very specific way on the bottom of either microtiter plate or larger dish to build various tissues. So we've been working over the past 2 years to essentially learn how to build various healthy tissues. Examples here with retina, blood vessel wall, skin. And then once these tissues are validated, shown to be scalable, we're going to build disease models on top of them. For example, melanoma on top of skin with the blood vessel wall model. Actually, Francis Collins is interested in building model of progeria, which is premature aging disease. With retina, we're trying to evaluate compounds that may have toxic effects and destroy retina, as well as those that can protect retina from various external damages. So this is all work in progress, and we hope to build expertise in multiple types of tissues and then build disease models on top of them and build these instances of small tissue patches. You can imagine 2 by 3 millimeter sort of instances of blood vessel wall, skin, and whatnot as a multi-instance array, whether it's going to be on microtiter plate or another type substrate. We haven't decided yet, but we have engineering team on site to be working on the hardware aspect as well. You can imagine the challenges in this space. You have to develop not just the tissue models, you have to work with instrument vendors to develop detection technologies as well. You can't just put some of these things under a microscope and get the right type of data. You cannot just use 2-photon excitation. You'll need to develop high throughput slicing techniques and so on and so forth. Last but not least is building models that are even higher up in this continuum of 3D models. So I started by giving you examples of 1536 well-based 2D simple to grow cells in 1536 well plates. We can run millions of samples using those systems every week. In the middle are the 3D models derived from bioprinting. We're building those. Their throughput will be lower. Their level of complexity will be higher. Next thing that's closest to a live human or animal is actual physiological systems in chips or microfluidic cartridges. So this is an example of a program at NCATS that is extramural. We're not doing it within the intramural program at NCATS. It's actually done through grants with the external community. The goal is to develop in vitro platform that uses human tissues to evaluate efficacy, toxicity, other aspects of physiology, test new drug candidates, potential toxic molecules. So the goals of this program were pretty ambitious. The goal was to create all these tissues, physiological systems listed here, show that they're physiologically relevant, that they can be derived from different individuals to be able to explore genetic diversity and precision medicine one day, to show that these different organs can be connected together to recapitulate higher order of physiology, such as, for example, gut on a chip connected to liver on a chip, connected to kidney on a chip, and to show viability for at least about a month, and then to make those systems available to the community, as opposed to just keeping them in one lab. Really a prime example of team effort and team science. You cannot build liver on a chip just by knowing liver physiology or knowing where to get primary cells that are derived from the live liver. You will need bioengineering. You will need advances in detection, in informatics. You will need knowledge and expertise in material science to understand how to actually build these organs, because remember, you're taking mature cells and building an organ. You're not taking an embryo and asking it to turn into quasi-human. So very different order of building these organs and physiologies. So this was a partnership between NIH, FDA, and DARPA, Defense Advanced Research Projects Agency. That's a unit of Department of Defense. They're funding the engineering aspect, so they're funding MIT and Harvard VIS teams to develop the hardware. NIH through NCATS is funding various extramural PIs to develop the various organs. And of course, the expectation is to have participation from FDA with their expertise in regulatory affairs, and pharmaceutical companies and other customers whom you hope that eventually will use these systems and use them for regulatory filings. And then, of course, you hope to disseminate these systems through various startup companies and suppliers of these systems. So the program is entering its 5th year now. DARPA has supported the initial platform development and won't be supporting further development after the end of the 5th year. NCATS is continuing the support to provide for validation of these microphysiological systems and to initiate the adoption by the community. The program has made tremendous progress. No time to tell you really, but examples include ovulation on the chip, 28-day menstrual cycle, connection between liver, kidney, bacterial infection in lung. All sorts of physiologies demonstrated really well over the past 2-3 years by the various teams working on this. So where we're at right now is funding on the extramural side, the so-called tissue chip testing centers. So these are labs that are not the initial developers of the technology. They're, if you will, the beta sites that will receive actual instances of organs on the chip, physiologies on the chip. They will learn how to use them and will run various validation tests on them. So this will be the first instance of externalization of these organs on the chip. There are plans to fund later in the fiscal year various disease modeling efforts, and there is also partnership with NASA in the making to test some of these microphysiological systems, organs on the chip in space, to evaluate the effects of zero gravity on various aspects of human physiology. And you can pretty quickly see where this is headed. You can have one day, let's say, 100 different livers on the chip from 100 different individuals, and you can evaluate your drug for metabolic processing by these different individuals. or you can construct even more complex physiological systems that are individual donor-based, utilizing stem cell technologies to scale up the right cell types, not relying on specific primary tissue donations and access to rare tissue types. So really great promise in this area of precision medicine, as we call it, U on a chip. And we hope that one day we can actually achieve clinical trials on chip and of course, evaluate not just basic physiology, but bring in external agents such as infectious agents, test various models of viral infections, bacterial infections. One big challenge in this area is actually building the immune system. We're not there yet. It's actually very hard to build innate immune system in these organs on a chip. And the other technical challenge that is faced by the teams right now is, as they connect the different organs, the problem becomes, what is the blood? What is the universal media component that will flow through the various organs? When the different organs were developed, they all required individual, specially formulated media to keep those cells happy. So now the teams have to essentially work together and compare notes and come up with a medium that will keep all these organs happy to allow circulation of drugs, metabolites, and essentially to reach this higher level of complexity that you need when you start looking at multiple organs. I will stop here and be happy to answer any questions. Thank you.
Perhaps you can elaborate on the small molecules for the Zika virus.
So we've run one screen using neural cells, neural progenitor cells, astrocytes, and published those results. But this is just the beginning. Zika biology is so new. Nobody really knows what the best screening approach is. So what we're doing is we're actually setting up another half a dozen or so screens. So for example, we're working with NINDS team and team at Georgetown to set up a biochemical assay on NS3 protease from Zika. So it's essentially a protease biochemical screen, so going after a very specific target. We're setting up screens to test the progression of Zika infection by other markers. So in this first screen, we were just looking at host cell death. And we actually found molecules that were slowing the infection process, and also molecules that were helping host cells survive. So they weren't working on the virus as such. They were essentially boosting the host cells' defenses. We're working on setting up screens with labeled Zika. So there's a collaborator down at UTMB Galveston, Texas, who's developed luciferase labeled Zika and mCherry labeled Zika. So you can follow the infection, in this case, in the fluorescence case, by taking multiple time points and following the protein production as the virus enters the host cells. The first protein gets made, and then the virus starts replicating, and more protein is made. So you actually have burst, plateau, and then another uptick in protein production. And depending on the mechanism of action of your hits, you will see different effect on these time courses. So you can tease out mechanism of action probably directly from the primary screen by following over the course of 48 hours, 72 hours, with enough time points taken, because this is a non-destructive method of monitoring the progression. You just take the plate out of the incubator, measure fluorescence, and return the plate in the incubator. You can do it every couple of hours to build this very precise time course. So that's what we're setting up. And then with luciferase labeled Zika, the sensitivity is incredible because you have practically zero baseline with such assays. That's why luminescence-based assays are oftentimes preferred. They give you really strong signal over background. So all of these efforts are either ongoing or being started because we don't really know what method will deliver the best hits. Yes.
All the technologies you mentioned, which do you think has the best potential or already has to disrupt the really slow and inefficient failure-prone process of developing new medical interventions? If you had to make a bet, what would you want?
Well, I feel we need all of them because, again, what goes unmentioned with all these 3D models, next generation models, is how many compounds can you test? How many molecules can you realistically test using each of these platforms? Using tissue chip, you're not going to be testing thousands or even hundreds of molecules very easily. You'll be able to test a couple of molecules in very detailed way. You will be as close to living human being as possible. But again, you're paying the price in terms of throughput. So we view this multiplicity of technologies as all being necessary and being part of this continuum. So they will be disruptive collectively. I don't believe that one of them will be disruptive just singularly because, again, you need to feed tissue chip with very few molecules, but which molecules are you going to use? You will need the lower tier 3D models to inform you as to what to progress to tissue chip and eventually to humans. Yes.
So the tissue chip initiative is really cool. And I was just wondering if anybody had considered whether or not the microbiome could ever be incorporated in that sort of system. I mean, because, you know, it seems to that we're sort of scratching the surface on how the microbiome really does interact with all the drugs that we take and how our body works. So I was just wondering if anyone thought
Right. Well, there is intention to do that. There is no specific grant mechanism for it right now, but probably within a year or so there will be, because you first need to essentially stabilize the wild type system, the gut on the chip, and whatever else you want to apply microbiome to. And then you can begin to layer this next level of complexity to it, exposing these organs to either one bacterial strain, commensals, or whatever your experiment calls for. But with the advancement of detection techniques, this will be a real possibility, because you can imagine with the organs on the chip, there are various ways to embed fluorescence reporters into these tissues to report on the physiology within that tissue, but you can also have sampling parts to take samples in a non-destructive fashion and evaluate what happens in terms of metabolism and signaling, secreted exosomes and whatnot.
One more. Why do you use tissue chips in space?
So we haven't done it yet. This is of interest to NASA because there's a lot of preparations. I mean, they've been ongoing for decades for very long space flights. So you can't really run a phase 1 clinical trial of sending a human to Mars just to see what happens. You really have to be ready, right? So how can you be more ready for such very long duration flight? Sending organs on a chip in space is one way to continue to evaluate human physiology in these extreme conditions. So that's one rationale, really. there is also accumulated knowledge that humans age faster when they're in outer space. So studying these processes of accelerated aging is also important and can have direct therapeutic consequences for humans on Earth.
Thank you for this fascinating lecture.
Thank you.